So it's a pleasure to be back in Seattle. It's an epicenter of ultrasound. So there are giants here, but there were giants that preceded them. And Seattle and University of Washington continues to be the place in ultrasound and the place that a lot of technical, clinical, and commercial development took place. And it's great to see that you're here. The first time I was here was 43 years ago when my boss sent me to Seattle, across the Atlantic, to meet the people who were doing Doppler ultrasound, which was a duplex ultrasound. Doppler ultrasound was a new modality then. And before I begin, I'm going to say that I have no disclosures, but I will be talking about off-label use of microbubbles. And I want to acknowledge the people at my home lab in Toronto, my colleagues, and also some colleagues elsewhere, radiology colleagues, Dr. Wilson and Hyungjung Jang and Tae Kim especially, Dr. Hinanin, physicist in our group, and Drs. Verschlaus and Jensen, who are from the University of Twente and from Copenhagen, respectively. And they've all given me the material that I'm going to be showing you today. We're going to talk about the circulation. And now it's obvious that any radiological examination has a vascular component. And in ultrasound, that vascular component was provided by Doppler. And it was to Jean Strand-Ness in the Department of Vascular Surgery and Jean Primizic, who's sitting right there, to whom I was sent 43 years ago to learn about what they had done to create the beginnings of the peripheral Doppler ultrasound examination. And that resulted in this kind of study that everybody's familiar with Doppler showing a big vessel, portal vein, and hepatic artery here. But the liver, of course, is a bag of blood, and Doppler doesn't show that. And the reason it doesn't show it is that Doppler detects motion, and when the motion of the blood, its velocity, is comparable to the velocity of tissue, you can't distinguish the two. In order to distinguish an echo from blood from an echo from tissue, you need to put something in the blood. And what we put in the blood are microbubbles, injectable microbubbles. They're the size of a red blood cell and less. They can stable enough to pass through the pulmonary and cardiac circulations. And they give us echoes in tissue that really enable a completely new kind of imaging, an imaging in which we see perfusion and perfusion structures, in this case, hypoperfused metastases in the liver, or lesions such as this focal nodular hyperplasia, and another one here. And you'll notice you can actually see little dots moving. We're seeing individual 3 to 4 micron sized bubbles, perhaps 10 centimeters below the skin surface. And we can see at the bottom right, completely new kinds of ultrasound images of perfusion and vasculature together. Kind of images we certainly don't ever see in real time in radiology, but here with a regular handheld transducer and just the simple injection of bubbles. And people have taken these bubbles further, not just as a contrast indicator of vasculature, but also as an indicator of specific targets. They've been associated with ligands, here VEGF and selectin ligands associated with vascular proliferation, VEGF, or inflammation, such as the selectins. And combined with this vascular imaging from the bubbles, we get a new kind of ultrasound-based molecular imaging that's just entering human trials now. But there have been surprises. I don't think anybody who started off looking at these bubbles ever thought that they would also create new therapies. And it now is apparent that bubbles can be used not simply to get to targets and not simply to carry drugs and genes to targets, but to be able to change the targets, to be able, for example, to parate a cell membrane and expedite the introduction of drugs into cells, to open the blood-brain barrier, which we'll come back to, a very significant breakthrough in medicine using bubbles, but also to kill bacteria, to disrupt biofilms, infections, and to penetrate and even deliver drugs into thrombus, so-called sonothrombolysis. So these are new areas that have been facilitated by bubbles that we never really expected. And I thought I would like to begin by talking a little bit about a quick summary of what we know about bubbles. And I think the first thing to point out is that unlike the other contrast agents we have in radiology, gadolinium and iodine, bubbles occur naturally. They occur in the natural world, and sound occurs in the natural world, unlike X-rays and oscillating magnetic fields. And for that reason, biological nature has taken note of them. And there are a lot of examples in the animal world of the interactions between bubbles and sound that can both illustrate and actually inspire some of the things we do in biomedicine. So I'm going to begin by talking a tiny bit about the natural history of the acoustic bubble. So the story starts in this. It could be, I guess, a scene from the Pacific Northwest, but it is in fact a Scottish loch in 1943. And scientists have been dispatched to the loch because the newly developed sonar, which has become crucial in the War of the Atlantic, doesn't work when it's raining. So if you stick your head underwater, that's the kind of sound you'll hear when it's raining. And it's not just the sort of percussive sound of drops. It's kind of a little bit musical. And if you look at a drop hitting a surface of water, you see the Rayleigh jet that comes back up. Here's another drop doing the same thing. And I wanted to point out these two little bubbles. So in both cases, the drop has hit the water. It's entrapped a tiny bit of gas and is pushing it underwater. And if we look at that motion in relation to the sound, we see at this point where the drop has hit the water, there's no sound. And a small time later, a few frames of that movie later, the bubble appears and the sound begins. And you can see that the sound is sustained. It has a particular frequency. That bubble is ringing, it's resonating. So the sound of rain is in fact the sound of bubbles. And that bubble, by the way, is tiny. It's sub-millimeter from a single droplet of rain. But the oscillation of the bubble, which emits the sound, results in the diffusion of the gas inside the bubble into the medium. So it's a tiny little bit of atmospheric gas has gone into the medium. But there's an awful lot of bubbles and an awful lot of noise in the oceans. And that process that I've described sequesters about 1 billion tons of atmospheric carbon into the oceans every year. Not enough to compensate for what we're doing, but still a huge contribution to stabilizing the climate. There's another sound. You hear that? The sound of opening a can of beer. You hear the sound as the pressure drops of the bubbles coming out of solution. The bubbles get larger and their resonant frequency drops. And so we hear the pitch drop as we do so. And then finally, another example of resonant oscillation of the bubble, this time bubbles which are placed in the vasculature and the pressure is changed by insulating them with ultrasound. And that's called forced resonant oscillation. And that's what gives rise to the echoes that we're talking about. So we're all familiar with the concept of resonance like a musical instrument, but bubbles can do something else. They can do the opposite. You know, with a resonant object, we excite them just once and we get this sustained oscillation from them. But bubbles can do something else. When the pressure in the fluid environment lowers, a bubble will come out of solution. And if the pressure then goes up to a sufficient level, the medium will be pulled apart to create the bubble and then will snap shut and the bubble will disappear. So that process can also be induced by sound. Sound is, of course, oscillation of positive and negative pressure. The negative pressure creates the bubble if it's big enough. Positive pressure slams it shut, sometimes even in the next half cycle. Or the bubble can take a long time to grow and then suddenly be snapped shut. And that process is called cavitational collapse. And you'll notice here, this is from Tom Matula. So many of the slides I'm going to show you have their origin right here at the University of Washington, been studied by Tom's lab for many years. Now, what happens when the medium is slowly drawn apart? It takes a lot of energy to do that. And that energy is returned when it snaps shut. But what the bubble does is it concentrates that energy into a single point that's very small and does it very quickly. In fact, some of the shortest events man can make, femtosecond events, are the collapse of a bubble. And what does that mean? It means extremely high temperatures are achieved, hotter than the surface of the sun, so hot that there can be conversion of that energy to light, sonoluminescence, or to even X-rays or gamma rays. So bubbles have this ability to return energy very rapidly and focus it in a point. And that's absolutely unique to the combination of bubbles and sound. That process, by the way, of sonoluminescence was one of the last unsolved problems in 20th century physics, put to rest principally by Detlef Loerse and colleagues at the University of Twente. So here's one other example of bubbles. And this is a propeller or a hydrofoil on the left. And of course, the way they work, like wings, is that the fluid goes over them, pressure is drops, and that gives the lift that the hydrofoil needs. But the pressure also creates bubbles that cavitate, and you can see them here sort of exploding as they collapse on the edge of the propeller. And that's enough to ionize the steel and make holes in tensile steel. So this is not just a little phenomenon, this is a thing that can destroy great lumps of steel. So let's now look at another sound from nature. So you can hear this. A bit soft, isn't it? It's a kind of crackling sound. It's the sound that you'll get if you stick your head under a different water, the Gulf of Mexico. Did say Mexico. Yeah. And we're listening to what are called, often called snapping or pistol shrimp. So they make this snapping noise as they're fighting. They use it for communication as well. And that's what all that crackling is. Millions and millions of little shrimp. But the interesting thing there is, I mean, it's very hard to snap your fingers underwater. It's very hard to slam anything together underwater. And actually, if you look at the snapping of the shrimp, it actually is not the snapping of the claw at all. The claw ejects a jet of water, pressure drops around the water, cavitation takes place, and that sound that we hear, once again, we can look at the movie and see that when the claw snaps, no sound, but when that bubble collapses, we hear the sound. So that energy is released, and that's enough for a shrimp to kill its prey. In fact, amazingly, you can see sonoluminescence from the snapping of a shrimp. So a temperature greater than that of the surface of the sun, caused by, that's an animation by the way, caused by the shrimp claw creating a jet that releases all of this energy. And that energy is the same energy that is used, for example, to break up kidney stones in treatments using ultrasound that have been around a long time. And we can also harness the same process, as we'll see, to collapse bubbles that will eject drugs from a bubble into tissue. And we'll come back to this. These are fluorescently labeled liposomes being squirted into tissue in the same way that the shrimp is squirting those bubbles into its prey. So let's go back to medicine. The bubbles that first started being used were just being used as some sort of passive enhancer of an echo in echocardiography in the late 60s. And then by 1980, people were making encapsulated bubbles that were stable enough to survive transit through the capillary circulation of the lung. By 1990, we had the kind of bubbles that are now used and are approved for clinical use, which are generally use a perfluorocarbon gas, which makes it more stable with a lower solubility in blood, and a shell that's either a lipid or a protein, usually a lipid, but there are now shells made out of polymers and other materials too. They were approved in the late 1990s in Europe and Canada and most of Southeast Asia, but it wasn't until 15 years later that the FDA approved them. So they're relatively recent comers to radiology, especially in the United States. You do remember the FDA, don't you? It was here last week. And the first thing that was found with these bubbles is that they're very effective. They're sort of efficient. A whole body dose, unlike in iodine, for example, which might be a little jug, is about 0.2 of a mil, 200 microliters, tiny injection, just 10 to the 8 bubbles, and it gives an enhancement that's the same as increasing the power of the ultrasound scanner by more than 1,000-fold. So they're incredibly effective. And that enhancement is frequency dependent, and that, of course, gives us a clue that these bubbles are resonating. And it just turns out, it so happens that if we look at the resonant frequency of a free bubble, it depends on its size, just like the resonant frequency of a musical instrument depends on its size or the tension of a string. And for the bubbles that we need to get through the heart and the lungs, bubbles that are just 3 to 4 microns in diameter, smaller than a red blood cell, their resonant frequency is 3 megahertz, smack in the middle of the diagnostic frequency range. So this is really a piece of serendipity. I mean, if we didn't have this strange accident of nature, we certainly wouldn't have, we wouldn't be here today, and we certainly wouldn't have a contrast agent for ultrasound. So there was just a bit of luck to do with the scale. So what happens when you have a bubble that is resonating and it's being forced into resonance by an external acoustic field? That is the transducer. In other words, we place a bubble that's resonating around 3 megahertz in an ultrasound field. And that behavior was first described by Lord Rayleigh more than 100 years ago. He was interested in the noise that his tea kettle made as it came to the boil, you know, that kind of creaking noise. That turns out to be bubbles moving through thermoclines in the kettle. And any authentic bubble physicist has the Rayleigh-Plesset equation tattooed to their forearm. And if you solve the Rayleigh-Plesset equation, you get which he, of course, did the long way, but we can do it very easily with MATLAB. And what we see is a bubble that's excited with this sinusoidal ultrasound is undergoing a radial oscillation that's very, very asymmetric. It kind of goes down and then bounces up, down and bounces up. It's going into nonlinear oscillation. And that nonlinear oscillation gives an echo that is not quite the same as the sound that was sent because it contains all of these nonlinear elements, these harmonics. And that's very similar to what you can do with a musical instrument. Anybody who plays an instrument knows there's always a way of mouthing a woodwind or of slamming down a piano key or whatever that will put it into nonlinear oscillation and enhance the overtones, which are the harmonics. And the harmonics, of course, are octaves above. So if we insonate at 3 megahertz, we get a harmonic at 6, 9, 12, and so on. And we even, with bubbles, get these ultra and subharmonics when they're in nonlinear oscillation, which are between the integer harmonics. So this means that we can send sound into the body, and if we just listen to the harmonics coming back, we're going to be able to pick out the bubbles and suppress tissue. And the way that's done is with a method that our student developed and that Matt O'Donnell there examined 25 years ago, something like that. And David is now working he's back in Seattle, right? Everybody seems to get attracted to Seattle. He's working out in Phillips, in Bothell. And what he did was he sent a pulse into tissue, got an echo back, and then flipped the pulse to the mirror image and got an echo back from that. So 2 pulses in quick succession. The echoes from tissue look like mirror images, and when you add them up, you get nothing. But the nonlinear echoes from bubbles, when you add them up, you just pick out the even harmonics. So this is called pulse inversion imaging. It's the basis of many of the imaging methods that are now used to produce pictures like this, in which we really suppress all but the strongest echoes from the diaphragm and see the bubbles preferentially in real time. It was also, incidentally, the first method in medicine that was able to see myocardial perfusion in real time. And that, I think, was a very important development as well. So, of course, it's patented, but like everything, it wasn't really the first. And fishermen have known for a long time that if they see rings of bubbles in the water, it's a good place to fish. And the reason it's a good place to fish is that these creatures here are already fishing. So whales and dolphins fish using bubbles. They blow rings of bubbles around their prey. They insonate the bubbles with their voices. And that causes the bubbles to go into resonance. The fish that are inside swim to this wall of bubbles, but their swim bladders resonate, so they shoal together. And here you can see, it's a bit stuttery, I apologize for that, I guess that's Zoom. These are dolphins fishing for lunch. You see that they're working cooperatively. You can see that some of them are blowing this wall of bubbles. I think you can get a glimpse of that. Others are insonating them, and they're driving there you can see the wall very nicely. They're driving the sardines to the surface so that they can eat them. But of course, when they get to the surface, not just the fishermen, but other animals know what's going on. So they're now in a competitive environment. And as we'll see in a second, there we are. They're birds. There's a whale who's trying to get in, and the dolphins are there, and it's their lunch. So they're underwater. They're using sonar, and there are bubbles everywhere, and they have to eat quickly their sardines and not the bubbles. And if they send out sonar, their echoes are dominated by the very strong echoes from bubbles. Here's the sound of the echoes. Very complicated sound, but it's dominated by the echoes from the bubbles. But in there are echoes from the fish. And how are they going to filter out the echoes from the bubbles, the echoes from the fish? It's the same problem that we have. And they turn out to use, actually, it doesn't seem to be pulse inversion, it's probably an amplitude modulation, but Timothy Layton discovered that these bubbles are using nonlinear sonar in order to do that, which is absolutely amazing, because in order to send two pulses and figure out what their sum is, you have to store the results of those pulses. And they have a way of doing that. And I don't think anybody knows how they do that. Okay, so this is where we go fishing with ultrasound in the liver. And I think all of you know that it's now a method that's been very convincingly validated for detection and differentiation of lesions in the liver, very important part of radiology. And it has some advantages, right? It's real-time, portable, highly sensitive. The agent is purely intravascular. There's no nephrotoxicity, and it has a almost impeccable safety record. So let's just look very quickly. Here's a liver imaged with ultrasound and with MR. The ultrasound can see the liver doesn't look very good at all. With the CT, you can't really see that anything's wrong. But when we add contrast to both methods, iodine to the CT, bubbles to the ultrasound, we get highly concordant images. But we would say that CUS offers advantages over that. For example, here are just a couple of cases that have been given by my colleagues. This is an MR of a lesion. You can see the arrow there, in which the enhancement of the lesion is gradually increasing, progressive enhancement. Well, if it was malignant, you would expect there to be washout. So this is actually in a patient at risk for HCC is an indeterminate finding. We do the ultrasound and we see enhancement and then progressive washout. So that means a malignant diagnosis from the ultrasound, not an indeterminate one. And this turned out to be a Hodgkin's lymphoma. So what's happening here is that the iodine for CT, but in this case, the gadolinium for MR is diffusing into the interstitium. So in the late phase, 5 minutes later, enough has diffused into the lesion that in spite of the fact that there's washout, you don't see it. The bubbles, on the other hand, stay in blood vessels. They're purely intravascular and so show washout better and more reliably. And that's been shown in a number of talks. And another aspect of ultrasound, of course, is its temporal resolution. So here is a lesion in a liver, a metastasis, and it's hypovascular. They're often called hypervascular because they appear to be hypovascular on CT and MR. But if we look at the ultrasound in real time, we see that in fact it's hypervascular, but it washes out very quickly. It's a cancer. It must have an arterial blood supply in order to be able to survive and proliferate. So it turns out that the majority of these metastases that were thought to be avascular are in fact hypervascular, but just have a very brief arterial phase. And if we just plot the enhancement of that, we see that what's called the arterial phase in CT and MR, usually after about 20 seconds, already this lesion is washing out. So the temporal resolution really helps in the defining of lesions. Like all ultrasound, the resolution is scalable with frequency, so we can have really beautiful high-resolution images. This is a femoral artery here. Cardiologist has been in and not come out elegantly, so there's a pseudoaneurysm, and we see this really beautiful depiction of the pseudoaneurysm as the bubbles leak out into it. And here is a aortic stent graft. It's being scanned for endoleaks with CT. And here is the same scan with ultrasound. Okay, not as pretty, of course. Ultrasound is not as pretty, but they both detect the endoleak. And in fact, a number of studies have shown that for endoleaks, ultrasound is more sensitive than CT, and that's simply because it's more sensitive to its contrast agent. But most importantly, these are patients often with impaired renal function, and there's no nephrotoxicity from the bubbles, whereas of course there is from iodine. If we move on to the sensitivity to flow, I'm sure you know that in classifying lesions in a cirrhotic liver or liver at risk from HCC, in order to determine that a lesion is malignant, there are really two important factors. One is that you see washout in the portal or delayed phase, and the other is that they're hypervascular in the arterial phase. And this is an example of an indeterminate study in which the arterial phase, the one on the left, is not showing, it's not able to detect hypervascularity in this relatively small lesion. But the ultrasound does, because it's so sensitive to the bubbles. And there you can see that bright spot there. You see the washout late. So by the LIRADS criteria, this has gone from an indeterminate LR3 into a definite HCC, which is an LR5. So that, if we go back to this detection of individual bubbles, this takes us to some interesting places. It means that, and I think David Hope Simpson did this as well, you can just track individual bubbles by just sort of leaving the shutter open, sometimes called temporal MIP, to create patterns of the path of the bubbles, even though you can't see all of the blood vessels. So this is a little breast cancer, and this is the same thing in a liver during a breath hold. And the bubbles are sort of showing us up to the fourth order branches of the portal vein. That's a hemangioma, that little defect in the middle there. And finally, we can disrupt the bubbles using ultrasound. So now this is not quite the same as cavitational collapse, all right? You can actually collapse a bubble and cause sonoluminescence and damage tissue, no question about that. But also you can, because the bubbles have this sort of soapy shell, if they expand more than 4 or 5 times their resting diameter, the shell will be disrupted and then the bubble will disappear. The gas just goes back into solution. And this is an air bubble. You can see it's going back into solution in a single ultrasound pulse. That's a millionth of a second. So we can now have a contrast agent, but by pressing a button on the ultrasound machine, we can increase the MI for a moment and disrupt the bubbles in the plane of the image. Then the rate at which new bubbles wash into that plane can measure flow. It's a simple indicator dilution method. And here it is in action, looking at the response of a big metastatic renal cell carcinoma. In the kidney, the lesion's perfused, we've flashed, and we've watched the new bubbles wash in. And then this is being treated by a sunitinib, tyrosine receptor kinase inhibitor. And 14 days later, the lesion's the same size. They don't shrink under these kinds of antivascular therapy. But when we look at the rate of wash in, and the level to which it washes in, which we can do very simply on the scanner, we see that it's responded in those 14 days. In this case, the vascular volume has gone down. Interestingly, in the same patient, excuse me, I just hit the wrong button. In the same patient, the MR study showed K-trans, which is a parameter related to flow in the lesion, going up, not down. So MR got it wrong, and MR got it wrong because of that big necrotic space. The gadolinium was leaking into the necrotic space in the tumor, and dynamic contrast MR can't distinguish between that and flow. So there again, the fact that this is a purely intravascular agent gives it an advantage. So going back to the ultrasound scanning itself, it's a form of echolocation, which lots of animals use, of course, and it's limited in its speed by the speed of sound in tissue. So, for example, if we make an image with 100 lines, then if we are able to get 5,000 pulses per second, that's a typical PRF. That is, if we have to wait for a pulse to come back before we can send the next one. So with the speed of sound in tissue, which is several thousand kilometers per hour, we can only do 100 lines in a 50th of a second. So we get 50 ultrasound images a second in a typical ultrasound scanner scanning a baby's head. That's fast for radiology, but it's not as fast as we would like it to be. And in the animal world, there are a bunch of animals, owls in particular, that use sound for navigation, but don't send out sound. They're stealth predators. So they fly and they listen for sound. Their face disc is an antenna, and they have specialized feathers that conduct the sound to their ears, which are just beside their eyes. And they listen to the ambient sounds in the forest. And from the reflections of those ambient sounds on the tree trunks, they can fly at great speed, at an amazing speed, through a forest and get their prey. They can also prey on rodents that they can't see, because in this case, it's something that's underneath the surface of the snow. They can go straight down and grab them. As they drop, they place their talons right in line with this disc, and they drop straight down. So some people who have been blind for much of their lives can walk down the street, and by the reflections they hear of the noise of traffic and so on, know where objects are, people, lampposts in front of them. Now, in ultrasound, there isn't ambient noise in the body, but we can do something kind of similar. We can send a very broad pulse of sound into the body and let echoes come back from everything. So we're not looking line by line and trying to delineate what we see. We just immerse the target in sound. And then all the echoes that come back form this complicated interference pattern. It's a pattern that's like the kind of pattern you see in a storm. Lots of sources of sound from different directions, different phases, changing with time. And you might think, well, it's impossible. Actually, I must admit, I thought it was impossible to unscramble this. And from the detection of this interference pattern, each of these transducers figure out what a target is. But the principle of superposition in physics is a remarkable thing. And in fact, with a little bit of computation, you can make an image from a single ultrasound pulse. So now we send 5,000 pulses a second, we get 5,000 images a second. And the result of that is really beginning to transform ultrasound. We're now doing Doppler so fast, Jeannie, that we can see red blood cells moving in a carotid artery. We have vector Doppler that is capable now of showing in real time not just the direction of flow, but we can animate recirculation patterns and have completely new visualizations of flow. I said a little bit of computing, but that was a kind of exaggeration. I mean, just a few years ago, this is a HD movie a second has to be processed by what was in that time an array of processors, 150 billion calculations a second. And it was sort of reserved for the specialist lab. This is Jürgen Jensen's lab. But then this guy comes along and we have GPUs that turn out to be perfectly suited for this. So for $99, you can actually do these calculations at remarkable speed. And here is a $99 thing thrown together in our lab. That Charles Tremblay-Darvaux has produced, gone back to that concept of the breath hold where we follow the bubbles, but this time following bubbles for just a fraction of a second, because the imaging is so fast, we can now track the movement of a bubble over a very short period. So this is a very fast image, slowed down, 5,000 frames per second, of a cancer. And now we track the bubbles using this temporal MIP, like the shutter open with these headlights, and we begin to see more details. And the more we look, the more details we see. So what we're doing now is we're taking a sort of blurry ultrasound image and creating, by following the tracks of these bubbles, an image that is partly an anatomic image and partly a calculated image, which is a sort of interesting thing that obviously is going to be part of radiology in the future, like what's real in an image that we create. So these tracks here, using this curvature analysis, which by the way has been part of MR angiography for many years, we're seeing these are the same image, but they're simply been processed in a different way. And what we're seeing now is near the resolution limit of the ultrasound. The resolution limit of the ultrasound, defined by the frequency, is a fraction of a millimeter. But this can be taken further. It has been taken further by the optics community. So they look at fluorescent blobs of light, see them moving, and say, well, who cares about the size of the blob? That's the point spread function of the imaging thing, the thing we're fighting to get better. But they don't care about it. They just put a dot in the center of that splodge and track that. So this is sometimes called super resolution imaging. What it does is it turns an image like this into one like that. We're just tracking single points. They have single points from their fluorescent targets. We have single points from the bubbles. So now by just waiting for enough bubbles to perfuse this kidney, and we're waiting 10 minutes, we can make images that are super resolution, that are spectacular resolution, that have never before been seen in ultrasound or any other radiological method, actually. Here are the capillaries of a brain, 20 microns in diameter, made by the Paris group of Michael Tonter. And this was published in Nature in 2015 and has really begun a whole new era in trying to figure out how we can do this in the clinic. This took 3 minutes to produce. We want to do it in 3 milliseconds. So this is the kind of image that you can get of a rat kidney by tracking the bubbles in it. And I think you will agree, these don't look like the ultrasound images we're used to. And because we're tracking the bubbles and can measure their velocity and direction, that image comes along with the same velocity and direction information that Doppler would give us too. So super resolution images now, the challenge is, how do we actually, we can track bubbles at great speed, but what we have to do is somehow deal with the fact that this organ is moving. So tissue motion becomes really the center of a lot of research. And I'm not going to go into that area, but it's a extremely important and challenging area, and one that I know people here at the U are studying. So if we move on now to the bubbles quickly, and we talk about how we can fiddle with the bubbles to make them do new things. There are all kinds of strategies. They're quite large from a biological perspective, very large from a biological perspective. We can incorporate oils which are compatible with the lipids. Those oils are very good for incorporating drugs which are lipid soluble. We can add all kinds of ligands to them. And it turns out that because the bubbles are so big, you can add ligands that will enable the bubble to hang on even in the shear stress of a major artery. And here's an example of one simple conjugation to a VEGFR2 receptor. This is with our lab with Stuart Foster. This is a 40 megahertz scan of a melanoma in a mouse. And you can just see those green dots beginning to stick as they gradually encounter the VEGF receptor, which is a signaling proliferation in that tumor. And after 5 minutes or so, it looks like this. And then we disrupt the bubbles using the ultrasound with a pulse, and they disappear. And the difference in green between these two images is some kind of measure of the expression of VEGF in the tumor. So that's important because VEGF is not just a target for therapies like the VEGF antibody, bevacizumab, but also the downregulation of the receptor is essentially a measure of the effectiveness of therapy. Unless we have molecular markers like this of the effectiveness of targeted therapies in medicine, we will be lost. We can't keep on just measuring tumor size with RECIST criteria and think that that's going to help an oncologist. Those days have already passed. So back to the University of Washington, this is Larry Crum, gave me this beautiful picture of what ultrasound, when bubbles are disrupted near the membrane of a cell, what ultrasound will do. And it makes all of those little holes. It's called sonoporation. And here what we've done is taken a cell and paraded it in an environment with a labeled sugar analog. And using flow cytometry, we can show not only that the number of cells paraded is very high, 80% in this case, but almost all of them are viable. So these holes enabled the cell to let a drug in and remain viable. And we can see why if we look at an endothelial cell being paraded by one bubble, and here within 20 seconds, it's resealed. So this is a reversible process that we can do to cells in order to manipulate their contents. So big question is, how does this happen? How does a cell open up a hole when we just have a bubble nearby? And one possibility is that when the bubbles are oscillating, they induce currents around them, convective currents of electrolytic fluids. Here is an example of one of those from Eleanor Stride in Oxford. And that those currents create shear stress on the cell, which makes a pore. The other possibility is that we are making bubbles collapse. And in fact, we can choose to do one or the other. So here on your left is a bubble under a microscope at 200,000 frames per second being insulated, and it's throwing out these streams, notice those convective patterns of fluorescently labeled doxorubicin into cells which hopefully have been paraded, membranes that have been paraded with holes in them right nearby the bubble. And that's one of the tactics of drug delivery. Another one I've already shown you is when you collapse a bubble. This is a bubble here, but it's been loaded again with the fluorescently labeled drug. And that cavitation energy is projecting over an extraordinary distance from a biological perspective into the cell. So there are many new constructs, and I certainly don't have time to go into them, but here's one from Rotterdam in which they are loading liposomes onto the bubble. These are microbubbles that have been coated with nanoparticles, and nanoparticles also can be sort of like little grenades that explode liquid particles, perfluorocarbon particles containing drugs. This is a stem cell that has been decorated with bubbles. They call them stem bells because the stem cell is now responsive to ultrasound and can be excited again near cell membranes with the hope of getting them into cells. This little face here is from our lab. These are nano droplets, liquid droplets, much smaller than bubbles, and they're not intravascular. They will permeate into tissue, and then we can excite them with ultrasound and boil them, literally, to become bubbles. So then we have bubbles inside interstitial tissue, which we could use to deliver drugs and break up the tissue. Here's another. These are polymer nanocups that stabilize bubbles, again, containing drugs. And I think this is a really amazing one. So this is from Mikhail Shapiro in Caltech. He's taken vesicles that are inside bacterial cells that are used to help bacteria float. And he has programmed them, genetically programmed them, so that they respond physically to the presence of genes nearby. So gene expression actually modulates the echo properties of this contrast agent. It's the first reporter gene in radiology. It's only been used in animals now. quite deservedly got onto the front page of Nature because it's an amazing breakthrough. Who would imagine that ultrasound would be used to image gene expression at that level? And then quickly, the bactericidal. This is really just delivery of a drug. In this case, it's gentamicin with bubbles. And here we're looking at chronic wounds, most of which are from these bacterial films that antibiotics won't penetrate. But in the presence of a bubble, locally, you can see that the antibiotic is delivered, the film is punctured. And this is a simple, but it could be a very important future application of the bubbles. So I want to finish with another, I think, remarkable picture. This is from a former student and postdoc of ours, Brandon Hellfield. He was in the University of Pittsburgh, and he made this picture of a bunch of endothelial cells that are forming the lining of a blood vessel. And there is a bubble right there in the middle, and he's going to turn on the ultrasound. The bubble is causes poration. There's a hole in the cell. That red going to the cell nucleus is propidium iodide. That's just a marker that confirms that the cell has been porated. But if we look 5 minutes later, you see the time on the left. This is speeded up. What this endothelial cell is doing is signaling to its membrane to detach itself from its neighbor. So the cell adhesion molecules that normally hold the endothelial matrix together is being opened. Now, where is that important? It's important here where there is an endothelial cell barrier that we all rely on, the blood-brain barrier. So the whole of the nervous system, all the blood vessels are lined with an impermeable barrier. You cannot deliver drugs to the brain because they won't go through this barrier. You can get some other stuff to the brain through the barrier, as we all know, but it's not the kind of stuff that, for example, will treat a cancer. It's tiny molecules like alcohol and adrenaline and LSD. So Kullervo Hinonen has taken this method and turned it into a therapy. So he's built a phased array with 2,000 elements. It's a helmet. It's MR compatible. In the MR scanner, they can target a region and then introduce the bubbles into the patient, insunate that region, and open the blood-brain barrier. And I won't go into this in detail, except you can see here, gadolinium has leaked in this T1 image in little punctate regions, which are where the ultrasound beam from that helmet was. So it's an extremely precise way of locally and reversibly opening the blood-brain barrier. So this has taken a lot of work in animals, demonstrating safety, obviously, is a huge issue when you're messing around with the blood-brain barrier. But just very recently, they finished their first human study of the delivery, they had already delivered a chemotherapeutic agent, but here they're developing a monoclonal antibody. So this is trastuzumab, that's Herceptin. Patients with HER2 positive breast cancer respond to Herceptin, but die of brain metastasis because the drug can't get to the brain. And here they've demonstrated with radiolabeled trastuzumab that they are permeated the blood-brain barrier, opened it in this patient, and then delivered the radiolabeled drug effectively to that same area. So this is the first, or the beginning of a new field in, I think, in potential therapies, not just for acute problems like cancer, but also for a neurodegenerative disease. So this is my last slide. I thought, amongst the many other things that we've talked about here, I'd like to point out one rather interesting fact, that we started talking about the stimulation of a bubble with ultrasound. So that timescale is a fraction of a millionth of a second. That's the timescale of an ultrasound pulse. We talked about how with that stimulation, the bubble can collapse and cavitate. That event is 10 to the 9 of a second, 1,000 millionth of a second, actually less than that. It's usually a million millionth of a second or less. But these two phenomena give rise to a cascade of biological events. So there are physical hydrodynamic events, streaming of fluids. There's biochemical and other molecular signaling within a cell. So the time scale here is in the region of minutes. Of the signaling, it's seconds to hours. If we're looking at the change of cell function and gene expression, we're looking now at days. And in fact, when this is used to open the blood-brain barrier, it takes between 7 hours and 7 days for the blood-brain barrier to close. So this is a reversible cascade of signaling that takes place over 12 orders of magnitude of time. And trying to elucidate, to join the dots between all of these events, to understand how they go in one direction and then go back again, is a very interesting challenge for our field. So in summary then, the bubbles are extraordinary creatures. We've discussed how they resonate like bells and they emit sound, how they can collapse and focus energy in space and time in an unprecedented precision, create temperatures hotter than the sun, that they capture and sequester carbon from the atmosphere. They can make holes in propellers. They allow shrimp and other animals to communicate and fight with each other, dolphins and whales to fish. In medicine, they can make images of microscopic vessels with no interstitial leakage. They could measure flow in organs and tumors in 3 dimensions, better probably than other methods that we have. The bubbles help us beat the resolution limit of ultrasound imaging. They can be targeted to molecular and cellular moieties. They can be synthesized by bacteria, which are engineered as acoustic reporter genes. They can porate cells, open cell junctions. They can potentiate radiotherapy. I haven't mentioned that, but bubbles and sound potentiate radiotherapy through the ceramide pathway, it seems. And that's very interesting because anything that's potentiated by ultrasound can be localized because we can choose where to send the ultrasound, much better than you can localize radiotherapy treatment. We can carry drugs and genes, release them using localized ultrasound. We can create bubbles in solid tissue with these liquid nanodroplets. We can degrade bacterial biofilms, thrombus, and the extracellular matrix in tumors by ultrasound stimulation. The ECM is a big barrier to drug delivery. We can open the blood-brain barrier to deliver drugs, antibodies, and genes. And all of this comes about by transducing an acoustic signal into a reversible biological response over more than 12 orders of magnitude in time. So I hope that amongst that, there's enough to at least interest some of you and hopefully to sustain a future interest in ultrasound in medicine. Thank you for your attention.